All right. Well, welcome everyone. Good morning again. Thank you for joining us on today's Learning Network webinar on leading with some resources for postpartum needs and social and Nkechi Charles, and they are both joining us from UNC Chapel Hill on the 4th trimester project. So I'll let you guys go ahead and take it away.
Good afternoon. Thank you, Nishka and the City Match team for the invitation to engage. Nkechi and I appreciate space to share what we've been learning with colleagues regarding opportunities to lead with resources for maternal health. The conditions in which we are born, grow, love, become families, and hopefully thrive together matter. There's increasing attention to the ways in which daily life and health outcomes are shaped by political and economic policies, healthcare systems, resource distribution, and community networks. There are structural, commercial, and as Abigail Echo Hawk outlines, colonial determinants of health. These issues are not new, and the root cause of inequities and thereby health disparities are power dynamics, which, as Dr. Joya Creer-Perry and colleagues offer, are born out of a hierarchy of human value. We prioritize some and disinvest in others, and it shows. That's a lot to unpack and reckon with. I'm acknowledging the seriousness of this topic and the multiple levels of influence. And in this session, we're primarily focusing on institutional and interpersonal components of this story. The recommendations are directly addressable in clinical practice and public health programs. My broad goal as a researcher is to generate new knowledge and partner with those most affected to build on what's working well and co-develop solutions. In this way, we continually strengthen systems of care to better accommodate what people need to know, feel, and have happen to be safe and well. Our reproductive justice framework draws attention to investigating not only harms that can occur in the transition to postpartum life, but this concept also calls us to identify what assurances are needed to protect and promote maternal autonomy, dignity, companionship, informed decision-making, and other rights as part of our reproductive lives. I've shared this group photo from a research meeting, which includes patient representatives, clinicians, social justice advocates, and researchers, because this is what the work looks like. We meet in our community, in this case at a local kids museum, use first names, and have team shirts to help with connection around a shared purpose. Qualitative research enables us to hear what has been deeply felt. Then we follow through with action. So with that context, the objectives for this session are to define the concept of the 4th trimester, describe research findings on unmet maternal health and social needs, and list opportunities for healthcare systems to be more of an ongoing resource for all. And everything is at stake. Maternal mortality, morbidity, realization of health goals, and the trustworthiness of our institutions. Unfortunately, instead of this dream state of closeness and peace, we have systemic issues that often undermine respectful, equitable, and supportive care, and disproportionately so. Some people go great distances for healthcare services. And imagine after traveling 100 miles, you aren't seen, even when you're face-to-face with clinical staff. Decades ago, anthropologist Dr. Sheila Kitzinger suggested that there's a 4th trimester to pregnancy, a period of about 12 weeks postpartum, in which mothers and infants are a mutually regulating system. Everything that a baby can do only makes sense in light of the caregivers. and postpartum people navigate a transitional state in which changes in hormones, bodies, emotions, relationships, finances, and identities, while caring for a new person, themselves, and perhaps for others. And she warned that we neglect it at our peril. The spotlights are dimmed for people after childbirth. In American society, we do not pay much attention to the adults in the family once the cord is clamped. The underlying notion of women and all birthing people as being worthy of focus only while they are vessels for new life is deeply harmful. We see this play out in multiple ways. When considering maternal mental health, the fragmented and infant-focused system can lead individuals to internalize hardships. Mothers feel like failures. I am hopeful, though, that awareness is growing that maternal postpartum health care has been too little too late, and resources are increasingly directed accordingly to fix this. There are about 4 million birthing parents in this country each year with shared stories. An analogy that Dr. Allison Stubbe developed, and we published in this article, is that it's like babies are candy and mothers are the wrappers. Once the candy is out, wrappers are tossed aside. This transactional thinking and treatment around childbirth is a tragedy with short and long-term consequences. Any way you look at it, regarding health outcomes, financially, and most importantly, there are human costs. Babies are precious newborns, and we need to retain affection and care for people throughout the life course. In the 4th trimester, parents are born too. Yet we found that new mothers felt alone. They didn't have information they needed because they didn't know what to ask for, and they were expected to lead the planning. They searched for help but got no answers. They felt alone because they were. More recently, participants have described postpartum health services to us as aftercare, with the system being jarringly obvious that support after childbirth is not a priority. There's a mismatch of needs and resources. Participants also describe feeling judged and distressed about not receiving the care that they deserve. Similarly, healthcare teams are understaffed and ill-equipped to care for patients as they would like. These experiences are the opposite of the sense of belonging that we all strive for as social beings. Postpartum care has long been neglected. Indeed, the word postpartum itself is often considered shorthand for postpartum depression. We offer information in a checklist manner and structure services in silos, with guidance that is sometimes conflicting and without adequate care coordination. The reality is that health domains are interrelated. Participants reported that rest, recovery, and finding their groove was an ongoing process. They desired models of care that included tailored information through various modalities, such as texts, handouts, and in-person discussions, rather than a single regimented healthcare visit more than a month after birth. The figure here offers topics that resonated with participants, and it is not comprehensive. The 4th trimester research findings also elevated the importance of employment, childcare options, companions, and experiences of discrimination. Additionally, the mothers wanted to feel more at ease by proactively being informed when infants and young children were welcome in clinics, by establishing that there was no need for them to dress up for appointments, and affirming that asking postpartum questions were not bothering healthcare team members, but rather helping them to serve. Overall, participants called for more preparation before and through the fourth trimester, with provision of more credible and relevant information, timely access to risk-appropriate care, align priorities with healthcare providers to develop realistic expectations and to facilitate shared care planning. They also desired more shared responsibility for health instead of the onus being on postpartum people to obtain, process, communicate, and utilize services. In summary, for conceptualizing the fourth trimester, birthing people called for the healthcare system to move toward being a source of ongoing support instead of a place of last resort.
Well, thank you, Dr. Tully. I have the privilege of sharing about what we've learned through the fourth trimester project. Our mission is to transform the lived experience of the fourth trimester. We know that new mothers and families are facing challenges in this journey, including isolation, unrealistic infant and self-expectation, limited access to needed care, and stigma around issues such as mental health. We are grateful for the ongoing funding by HRSA that allows us to do this work. And this could not be possible without our multidisciplinary team members, including Dr. Sarah Beast, Kimberly Harper, Suzanne Woodward, and Dr. Tully. And among our community partners, we've had the privilege to work with in the past with Mama's Village Fayetteville, Welcome Baby in Durham, and are currently working with Citygate Dream Center in Burlington. Lastly, I want to especially thank the mothers and birthing parents whose voices, ideas, and needs we've learned from and we're seeking to lift up as we design the change that they want to see. Next slide. We have had the privilege of hearing from a diverse group of birthing parents, totaling 317 so far through focus groups. They come from 6 perinatal care regions in North Carolina. Today, I'm going to discuss what we have learned from the postpartum experience of our participants and give particular attention to unmet postpartum care and education needs. Next slide. Now, the fourth trimester is a critical transition period, one that could be particularly stressful for new birthing parents. Many first-time parents spoke of not being prepared for how physically and emotionally challenging the postpartum period would be. A participant commented, to me, this period was the most stressful period for me as a new mother, who is assuming new roles and responsibilities in life and must deal with the demands from her newborn baby and her own care needs. Another participant expressed, it was my first. I had to be like Superman and do it all. No one told me how to do all these things, and it was very stressful. Next slide. And it is not enough for healthcare professionals to ask if patients have questions. Coping through the fourth trimester can be hard for a parent to think about or ask questions. As one participant put it, doctors asking, do you have any questions isn't helpful when people don't know what to ask and or don't feel comfortable to ask. Another participant said, you don't know what you don't know until someone suggests it. This sentiment was often echoed in various focus group conversations. Participants identified gaps in their postpartum knowledge, suggesting the need for anticipatory guidance prior to the postpartum period. Next slide. Now, theoretically, the postpartum visit could be strategically leveraged to address knowledge gaps. However, participants' accounts suggest the contrary. The matter of timing was a particular issue participants brought up. Now, in 2018, ACOG recommended that all women should have contact with their OBGYNs within the first 3 weeks of postpartum. However, participants' accounts show that this recommendation is not being implemented universally. Some participants reported either having their postpartum visit 6 weeks after or not attending their postpartum visit at all. And visits that were at 6 weeks postpartum left some participants feeling forgotten and unsupported. Next slide. The imbalance of medical attentiveness during the antenatal period and postpartum period was very jarring for some participants. One participant explained, "It feels like you're forgotten about. Leading up to the birth, you see doc every week, a couple of days, or you had a baby. They say, oh, you had a baby, see you in 6 weeks. I still need support, even if I don't physically go into the office. Can someone call me and check on me?" I am not saying don't check on the baby. I am saying I want to feel less like a vessel bringing a baby into the world. Similarly, another participant shared that waiting 6 weeks is very anxiety provoking. Nobody reaches out, they just discharge you and let you go. I would like this to be addressed better. And then lastly, here, a participant says, towards the end of pregnancy, you go to the doctor all the time, but then after you give birth, you have to wait 6 weeks. Why is this different? I need support, not necessarily to go into the office, but to have someone call me and let me know that I'm important. It seems to be all about the baby, and what about me? Next slide. Some birthing parents expressed feeling unsupported by their healthcare provider due to the brevity of the postpartum visit itself. A participant reported, "The only thing that made me feel unsupported is when you feel like the doctor is in a hurry or trying to stay on schedule. I get it because they have other appointments and maybe some of your questions can be answered later on. But there have been a few times when I felt like I didn't have time to ask questions." Now, the solution to have patients complete a form to document their concerns and questions prior to their appointment still left some parents feeling that they still had unmet postpartum needs. One participant described, "While I was waiting for the provider to come in the room, I had a form and that says, 'What are your concerns?' The times I did use this form, it was never addressed. It was pointless. You feel that pressure, your appointment time is over. We are all well aware they are on a time clock and they need to see the next patient." There would even be times where I was leaving the room and the form was still on the counter. In this way, some participants felt that the postpartum visit was not as meaningful as they had hoped. Next slide. Now we're going to use the figure introduced to us by Dr. Tully as a way to examine the unmet postpartum needs participants identified during the focus groups. We will see that birthing parents want more comprehensive postpartum education about recovery from childbirth and a broad range of postpartum topics. Next slide. It is worth noting that many participants reported conversations about contraception that took place during their postpartum visit. Though these conversations are critical, mothers felt that they should not be the sole focus of the postpartum visit. Next slide. Participants also expressed interest in having anticipatory guidance on normal infant development prior to their baby's arrival. Next slide. Despite the normalization and standardization of postpartum depression screening, there remains opportunities for improvement. Mothers desired early screening accompanied with conversations about postpartum mood. We also learned that there was an interest in mental health and emotional support, not just for the birthing parents, but also for their partners and support persons as well. Next slide. It was not surprising seeing breastfeeding as one of the challenges. However, birthing parents gave nuanced understanding of how some unmet needs reside at the intersections as opposed to the individual domains. For example, some participants expressed the need to understand how to initiate milk supply, how to manage oversupply, how pregnancy-related complications such as preeclampsia may affect breastfeeding. One could argue that this affects not only infant care and feeding, but other domains such as sleep and fatigue, physical recovery from childbirth, and mood and emotional well-being. Next slide. We also observed that there are other needs such as self-care, social support, and physical recovery reside in the intersections. Here, some participants reported being unclear as to when they can resume normal life activities. They also wanted to know what nutritional measures they should take to support the new demands on their body during the postpartum period. Next slide. Discussions around support were less centered around the absence of support and focused more on not knowing how to direct their families, friends, and even coworkers to support them in a way that's actually helpful. Participants expressed interest in having postpartum education specifically designed for their partners, their families, and their friends. Next slide. Lastly, participants expressed frustration at not knowing what is normal or not normal during the physical recovery from childbirth. Interest for more information included postpartum warning signs, cesarean section recovery, postpartum infection, pelvic pressure and pain, incontinence, and hemorrhoids. Now, according to the CDC, about 1 in 3 pregnancy-related deaths occur 1 week to 1 year after delivery. So it's important that birthing parents and their family be familiar with the postpartum warning signs. And we also found that many participants were not familiar with pelvic floor physical therapy that could help address the last 3 issues that I just mentioned. Next slide. Now, today we've learned from the voices of birthing parents that many are feeling unprepared for the postpartum period. They desire for a comprehensive postpartum care to meet their needs, not only for themselves, but for their partners and support persons. Postpartum support should not start at postpartum. Education needs to happen before the postpartum period. Strategies that integrate postpartum education earlier in the pregnancy, as well as provide proactive follow-up during the postpartum period, could help address these needs. Lastly, there's an opportunity for healthcare professionals and community-based organizations to partner to provide this comprehensive postpartum care. Thank you, Dr. Tully. You can take it for the next slide.
Thank you, Nkechi. So this is great. I mean, we've shared the definition of the 4th trimester as this special, part of the life course that has not received the attention that it deserves, and then shared what birthing parents have offered as priorities as part of whole person care. And so I think next I'll share some around social determinants of health specifically. And again, this is all part of our striving for comprehensive support more proactively. And I just want to address, the title of our talk is Leading with Resources, that if we are here to actively support each other and to connect with programs and services that are out there because there is such a huge need and we can benefit from them, then let's get to that as quickly as possible, as efficiently. And, there is a role for screening, but I think it's much smaller than the emphasis that has been placed on it. So this is recent work from Dr. Jen Fahey at the University of Maryland, where she's outlined, consistent with our message, the need for more proactive care. And that's really challenging when the system is fragmented and uncoordinated. Also, we divvy up, attention and programs, and that's a complex space when we think about, what does equitable care mean? But I want to draw attention right now to people are confused and overwhelmed when there are these, intricate processes to get to the services. And so we need, much more proactive communication, and people need people to walk with them through this process. So I'm here, to advocate for a midwife approach to this system. And so we did research recently where actually we were setting out to optimize the workflow for screening and referral, because as we've addressed briefly, sometimes we have forms and people fill out questionnaires. Sometimes that's pouring their hearts out, sharing their most vulnerable components of their life. And sometimes it's not read. And so it's really important to have a patient focus process for when should this be brought up. Should it be on an iPad or paper? Who should they give it to? Then how do we make sure that we're equipped to respond? So that is important. But what we found in this research, in this multi-method approach to shadowing and to listening through interviews and focus groups with birthing parents and healthcare team members, and I mean the front desk staff and nurses, physicians, pregnancy care managers, the whole team, around what their priorities were. And the thing that came out, and so we radically shifted to explore that in more depth, is that people were worried about how the information might be used against them. And so having colored paper to make sure that we see it, that's helpful. And we did PDSA cycles that incorporated that. But I want to share some more details around the things that people said were important through the process. Because there's, standardized questions, and I think there's a national conversation to make sure that we ask in a clear way about transportation and food and housing and domestic violence and other things. And the way that we do it shapes responses and our ability to take care of folks. And so this is what this project looked like. Again, we are here in downtown Durham at Welcome Baby in a community space, and we are literally on the floor with folks, and it's really fun and meaningful to be, not only have research be possible, but to be comfortable and to, in that way, be open and share what are sometimes very hard truths. And so these are colleagues from North Carolina State University. Kelly Umstead is the one kneeling by the blanket, and Carolina Gill is up as a native Spanish speaker facilitating the Spanish language workshop. And we use tools in a human-centered design process to engage in more depth. It can be a lot to tell me all the good and tell me all the challenges. And when you have artifacts or things to document and reflect and prompts, then that can help go in more depth in addition to the interviews. And so one of the things that people shared was that when you're dealing with unmet needs, you are not in the mind state to go research a lot. And so the consensus from these participants was for clinical provision of clear, actionable information so that people feel and are cared for. And during pregnancy intake and during early clinical engagement, made a lot of sense to them about asking and supporting. And they also elevated that before the first visits, in the first trimester, ideally preconception health, that we would have awareness and be able to utilize services. And so having it earlier and not be gate kept. And so they offered that offering social determinants resources was welcomed as part of standard of care for each patient. And it's interesting because we think a lot about humanity and healthcare. And when we present people a form, or when we greet them at the front desk, or when I meet you in real life or in a Zoom meeting, and you ask, how are you? We all always have a lot going on, and we decide what to share based on what seems appropriate, based on how much we trust people, based on time, based on energy, based on a lot of things. But no one is usually just fine. And fine's not what we should be going for anyway. We should be great and grateful, to be in a place that, where love abounds. But right now, care is structured where people walk in and then we say, please complete this form. And usually they have some framing. So this is the pregnancy risk screening form in North Carolina. And at the top, I know you can't see it, the point is that we hand people a piece of paper, and the instructions here say, please complete this side of the form as honestly as possible and give it to your nurse or doctor. The information you provide allows us to coordinate services with the care manager and provide the best care for you and your baby. So there's a few things there. And one is that only people who have Medicaid insurance are being offered this form. And the other is that this is sort of a lot, and it's a lot to take in, especially at once, before you've built a relationship with someone. And so there are, opportunities, and there are also challenges for being in this space. And I just want to highlight that among these include potential harms of screening. Nothing we do is neutral. And so we asked folks through the shadowing, we observed materials and behaviors and conversations, and then we interviewed people, and then we made index cards that had statements from the data that had been shared so far. And then these are the prioritized topics from birthing parents and healthcare team members. And this slide shares some of the top things that they said they needed to know. And among this includes why. Why is the clinic collecting this information? Can any of this be used against me and my family? And that's really concerning because we're all, here to do a lot of good, but that's not always clear. And will this be used to help me? And the clinicians want to know, is the clinic acting on this? Do we have people and resources to respond? And how do we know that we're matching resources to patient needs? They also need to feel respected, comfortable, confident, and that they're being trusted. And it's interesting that from, both sides of the team here, the responses are quite similar. And then we have a lot that needs to happen to accomplish this. And so I've included this image of one of the cards, and then the writing, and then the dot voting for the participants to prioritize the things that had to happen for this. And so birthing parents describe needing to know how their responses might be used, both against them or to help them. They need to feel confident about their care, acknowledged and respected. And along the reproductive continuum, birthing parents had negative and positive experiences, including at the same time points. And they desired experiences that included compassion, language concordance, and non-discrimination. Healthcare team members need to know that SDOH resources are there to address needs, and that the patient information is getting to the appropriate people for responses. They need to be aware of quality resources, and they want to feel trusted by the patients and comfortable communicating accurately around social needs. And so the healthcare team members wanted more support, coordination, and awareness of resources, with clinical leadership and managers coordinating the connections. And so, how might information be used against me was the very striking component of this. And so, we can address that, and it's critical to promote autonomy. And so this participant offered a quote about how we can introduce this aspect of care. And she said that it would be nice to say that we have a program available for this sort of thing, and would you be interested? And so then the patient can decide, oh, they have something to offer that might help me, instead of being like, well, do you have issues? And then people are like, well, why are you asking me? Because then they'll be hesitant, like, where's this going? Whereas I can think for myself, I have all the information to decide whether I want to answer a certain question. So this goes back to the I'm fine, we filter, and it's usually a tale of two stories depending on who's asking. And I think implicit in this, and I'll address this a little more in a moment now, is that if we don't have resources, we should not be asking. Unless we're going to use that information to go upstream for community strengthening. And that's, an immense opportunity. And I think not happening as often as maybe we could in the future. And so another participant addressed readiness of response. And so asking if you ask about, for example, food insecurity or housing, then what happens if the answer is yes? And are you equipped for that? And so she asks, is there a type of emergency protocol in place? Say I come in, I'm 3 months pregnant, and you give me this checklist. We're in the middle of the heart of winter, and I tell you I'm sleeping in the back of my car. One of my windows are broken, and I have 2 toddlers in addition to myself in the car. What's done? Do you call social services right then and there? Do you try to get emergency help in? Is that your place? You see what I'm saying? That needs to be something that you guys think about, because then if the physician is like, oh, wow, I'm sorry to hear that, maybe you should call such and such. Then me as a patient, I'm like, I am never coming back to you. And I'd be like, are you crazy? And so we developed this tool to address institutional readiness to engage in social determinants of health. And I'm grateful and in awe of my colleague, Dr. Amelia Gibson, who led this figure as part of our published work, which is open access. And so I know that this is sort of a lot on the page. I want to highlight that step 1 here from our perspective, based on the participants' responses. Step 1 is, have I shared all that I can without screening? If not, do that. Provide whatever information you can without requiring patients to disclose sensitive information or personal data. So we can move from screening and referral to normalization and leading with resources. And I think that, we have screening on here, and that's really helpful for tailoring information. But in a society where, 1 in 3 families has unmet diaper need, and so many families are food insecure, and transportation is challenging, and we don't have paid leave, then we can just assume that offering information, including for mental health support, that might be helpful. And I'm not talking about pages and pages of details, but being clear that there is information about this, and that we can offer more if and when you like, and you don't need to have a problem, just like with lactation support. You don't need to have a crisis to benefit from expertise. And so I have this bulleted list here to offer best practices as generated from our research. And these include engaging in social needs universally, being transparent about what this is and what it could be. Again, leading with resources, to integrate questions about social needs along with other, health history and family history questions. Engage with empathy, build relationship, and critically be strength-based. Let's ask about what's working well and go from there to address the real challenges. And so it's been really fun and rewarding to partner with UNC Health to translate these recommendations into the standard of care. And so this is a part of a UNC Health system-wide website that addresses the purpose and utility of social determinant screening. And I want to highlight, and I think you can, this was a collaboration that I was very privileged to lead. You do not need to have a problem or concern to get this information. Do I need to answer these questions? No. And, a website and a statement is not all that we need, but I think it's really helpful to have this open access for patient and families and clinicians to have a shared understanding of how we want to approach this. And there are examples, and I'd love to hear from you all, helpful links that, again, we can provide folks universally for timely and non-intrusive support. People like to receive, handouts and leaflets and links, and then they want to be able to view those offline and in their own time. And participants said they'd like to be able to talk through those with someone. And so this is an example of state level resources from North Carolina and the Maternal Mental Health Matters program that has, I think it's 3 pages or so of helpful links, and including in English and Spanish, and it has a little bit of information about what this is. And, a lot of these are free. And so more on resources for addressing social needs. We created a tip sheet for healthcare team members. Again, so when we're thinking about the interpersonal level, how might I engage? You can confirm that people are in a safe or brave space and that you're there to support them. Look at them in the eye. There's a lot of documentation that's needed and a lot of opportunity to move from clicking to caring. And so there are, things that you can say, and how might I say these things? We offer some language to normalize this. And I offered example of framing that we used in the PDSA project where we were working on addressing food insecurity. And I think part of this is being humble and clear that we'll try to help, and that's why we're doing this, but we might not be able to, but we'll do everything that we can. And just being honest, I think, is a key for ethical care. And so before I transition back to Nkechi and the 4th trimester project to, focus on the postpartum component, I wanted to restate that there's immense opportunity for whatever we're asking about to ask what's going well. And so when we affirm that, and that's very different, at least from the healthcare forums that I've seen, where it's, do you have a problem with this, with this, with this? What other concerns do you have? And again, concerns are valid and critical. And, as a whole person who wants to be well, fine and well and great, then it's really useful to ask about that, so that then you can leverage, your family, or you can acknowledge your education or whatever the privileges and supports that you have, to then also go into the challenges. And so we have a variety of tools, and Nkechi will share more about that now, where we have written that and we ask folks.
Thank you, Dr. Tully. So after a few years of co-creating with new parents as well as healthcare professionals and implementing new tools into clinical practice, we have created resources for families and healthcare professionals. Next slide. These tools are available for free on our website, newmomhealth.com. We also have a Spanish version of the website called saludmadre.com. Birthing parents and healthcare professionals alike can find information about a broad range of topics about the postpartum period. There is a provider link on the top left corner of the homepage for healthcare providers. There you will find the 4th trimester postpartum toolkit. And that's when for the next few slides, I'll be discussing 3 of those tools. Next slide. We have created 2 one-page health information sheets. One is a birthing parent health information sheet, and the other is a baby health information sheet. The sections include when to call 911, when to call the health provider, and information about taking care of both the birthing parent and the baby. These are both helpful for clinics to distribute during antenatal visits, so families can read on what to expect, and again at discharge or during postpartum visits. Next slide. We have also developed a postpartum planning tool for new parents with a lot of feedback through our focus groups. This is a guide to help parents think through ideas for support during the days, weeks, and months after birth. Sections include contact information, communication, visitors, food and groceries, ways that they can sort of list out what support means for them, and some additional resources. Like the other documents, this can also be distributed during the antenatal visit as well, so that they can have time to sort of think through with their family as to what would be helpful for them. Next slide. The 4th trimester project has also created a Taking Care of You booklet. It's basically a postpartum recovery support booklet. It's available in English and in Spanish. And it basically covers a lot of the information of what could be found on the newmomhealth.com and the saludmadre.com website. Next slide. We are also excited to share with you the 4th trimester project videos that are available. One of these videos we have created is What No One Tells You About Postpartum Hormones with Dr. Stubbe. These videos are designed to be around 90 seconds or slightly more, that can be easily shared through social media and viewed on the phone. This strategy was informed by our focus group discussions, where we discovered many new parents are actually going to social media to find information. And one of our goals is we want to make sure that anyone who's searching online can find information that's helpful and as well as accurate about the postpartum period. Next slide. So I will close with this just to say that ultimately the 4th trimester project wants birthing parents to know that they matter and they are not alone. And it is our hope that these resources will support them through their postpartum journey. Now I'll give it back to Dr. Tully.
Thank you, Nkechi. And so I'm really excited that, we increasingly and in community with others are developing tools that help and that are positive and have a nice affirming tone, because sometimes information can be scary, including intentionally. I'm excited to share this was just released last week. The Institute for Healthcare Improvement partnered with the Alliance for Innovation in Maternal Health, which is part of the American College of Obstetrics and Gynecology, to offer a change package for the postpartum discharge transition. And 4th trimester project team member Kimberly Harper and I were both a part of this working group, where we reviewed the existing evidence-based guidance on core parts of immediate postpartum period and setting people up for success. And then we offered thoughts for how to operationalize that in practice. And so that is available open access as part of a whole toolkit, or these, bundles around different aspects of maternal health on saferbirth.org. And I want to highlight, and I think you'll hear us, through this national best practice guidance includes recommendations to implement universal screening and lead with resources and not leave patients to make referral connections themselves. Co-design of comprehensible relevant materials, including with the after visit summary. Sometimes those are 15 pages of documents without information hierarchy. And so information about blood pressure or other very important components might be buried at the bottom of page 4. And so there's opportunity to strengthen materials so that they are, worth reading and useful. Another aspect of this change package is ensuring access to hygiene supplies. So by that, I meant menstrual equity. And so people don't always have enough access to pads when they're in birthing facilities. And they certainly might not have availability even for the ride home or in those first weeks, despite the universal component of postpartum recovery, including lochia and healing in that way. And even though postpartum hemorrhage is one of the leading direct contributors to maternal mortality. So when we talk to people about bleeding through 1 or more pads an hour, we might also be ensuring that they have pads. So check out the resource for a lot more details. And we have 2 last slides before we open it up for discussion. And I want to read the chat. I see that there's some comments there. And so, what we've been speaking to is the cycle toward respectful care for more just systems. And a lot of the workarounds or the, individual addressing social needs, I would characterize those as retrofits. As Dr. Monica McLemore outlines, we need to retrofit, reform, and reimagine for health equity. So retrofit means, given the current state of the system and the constraints that are in place and the scarcity mindset that's so pervasive, then what can we do to help now? What are the, more individual level actions and institutional that we can take? And we've shared some of those today. And part of that is reforming the system, right? To have postpartum visits, for example, be more comprehensive and more ongoing communication instead of the one, later. There's a lot to do to actually implement that. And reform, also means integrating our communication and tools to be strength-based. And of course, and I want to emphasize that we need supported healthcare team members with safe staffing in both outpatient and inpatient, especially, nurses, to be able to do that. We can't just ask more and more of fewer people. And we want them to be thriving too. And so at the same time, we can also reimagine what care can look like. And so instead of trying to cram everything into the inpatient stay, might we expand home visiting programs and others? And, there are a lot of ways to undo and reconstruct the system of care. And there are concrete ways to operationalize that too. I think a lot of what we talk about is aspirational, and we need that because we're in a crisis. And Dr. Stubbe and I recently outlined, some of the things, and I've put like one example here, but the list is long. This is an open access publication where we give some examples of what it means to first do no harm. And I think that's where a lot of the work is at, is recognizing what that is and for whom, and what we can do to stop that. Then we want to be accommodating. And I think you heard that word from us multiple times throughout this session. We want the system to be appropriate and clear and accessible. And, we need all the doulas and patient navigators. And it would be a dream to eliminate the need for that. Like if it were clear who you could ask and how to navigate, then we wouldn't need to have those folks, but we urgently do right now. And then we have an immense opportunity to uplift. We can demonstrate respect and love and care, and have people feel really great about the resources that are there and feel taken care of and set up to thrive. So thank you. Nkechi and I are available, as well as other team members, and I'll stop sharing now so that we can see you and read the chat and talk. Thanks.
Thank you so much to the both of you and to everyone and their questions. It was just really exciting to see kind of the networks that were forming and just the information that was going back and forth. So yeah, just like Dr. Tully said, we'll go ahead and open the chat. And if you have any questions, please feel free to unmute yourself as well.
Hi, my name is Kelly Steinbeck-Tracy, and I'm from Denver, Colorado. And first of all, I wanted to say thank you for this amazing information. And my question is around, it seems like the kind of the call to action here is reform around kind of healthcare delivery in the healthcare setting. But at the end, you mentioned sort of this extension, this kind of reimagining what healthcare looks like, including the idea of some postpartum home visits. And I'm curious, we're trying to implement Family Connects in Colorado, which started at Durham at Duke University. And I'm curious what you see as potential collaborations I guess I'm curious what makes sense and is feasible to happen in the healthcare setting, and what maybe could happen in other settings like the postpartum visit. And just your thoughts on that in general. I love all of these ideas, and working in a health system, I know how hard it can be to do this kind of approach given the time pressures that are created by the reimbursement policies and that sort of thing. So.
Yeah, reimbursement is, I don't know if that's a reform or reimagine for, preventative healthcare and wellness. And Nkechi, I'm looking to you, and Sarah, I know you're on. So Family Connects and other programs are amazing and evidence-based, and they change outcomes. So does midwifery care and so many other, components that have not been well supported. And so yes to that. And Nkechi, do you, I mean, I think you asked about what's feasible, and I think innovation is very much about the will to change. We could do anything if we wanted to.
And I do know that there have been some clinics here in North Carolina that have been grappling with that same kind of question. And we're right now working with different teams. Oh, and I see Kimberly Harper. Kimberly, do you want to say something with this? Because she works with a lot of clinics in the implementation process.
Sure, we actually have several facilities that have integrated this in different capacities. So we have some that have taken the postpartum care plan and integrated into their group prenatal care. So whether that's centering or it's another type of group prenatal care, they've taken the one-sheeters and integrated it into their sessions at like 28 weeks, and they start having those conversations early on. We also have another healthcare system that's taken our one-pagers and they've integrated it into their AVS or their discharge forms to help them so that they have the information ahead of time. The key piece that we've looked at is increasing knowledge related to postpartum care and kind of having that anticipatory guidance early on, making sure that they know, getting people access to things early. And so when it comes to the integration from either that we've had healthcare systems, we've had health departments that have integrated the postpartum plan and created postpartum classes. So they have their childbirthing class, then they actually have a postpartum class. We have one facility that is creating, they're redesigning their postpartum education to use our postpartum one-sheeters and to look at what that might look like and how to redesign. So there's several different ways where we've worked with places that have integrated into either the healthcare system from the hospital's perspective or an outpatient setting. And we've also done some things with some of the community-based organizations like doulas and lactation consultants to help them to know more about postpartum warning signs and educating like their whole group and team around them so that everyone is aware of what to do.
One more point about Family Connects. I don't know, Jenny Jensen, are you on? Jenny is the director of nursing at Family Connects and is a colleague. And so, yes, we have concrete plans too to partner and grow in the way that she sees fit.
I actually have a question kind of going back to the focus groups that you mentioned, as well as the resources. So I was wondering if all of you had seen a need for possibly creating, or not creating, but like having other languages available as for interpreters to come within the areas that you guys have worked in, because I mean, and not everyone is native English or Spanish speakers. So I'm just wondering if there are any other languages that you guys have been trying to incorporate into your focus groups and materials.
So right now, our focus has been focusing on Spanish speaking individuals. From the hospital perspective, we do know that there are other languages that do need a support. One thing I'm currently examining is the difference between simply translating something and adapting something. And so we are walking that through right now with our Spanish speaking tools, just really examining like, how do we actually discuss the postpartum period and what makes sense culturally and relevant. And so that is a need I definitely recognize. And it just takes time of learning what it means to really adapt, not just translate, but adapt tools for different cultural groups.
And I'm sorry, go ahead, Dr. Tully.
I was just going to add, we've done in another related project, the postnatal patient safety learning lab, we've done a lot of work with interpreters and with language concordant care. And despite the legal mandate, that is not universally occurring. And for postpartum people, including at rounding, sometimes at all during their postpartum hospital stay. And there's immense opportunity too with prenatal and postpartum care with, again, after visit summaries because we have, video, we have in person, we have video, we have phone, but sometimes with the written materials, people can have nothing. And so we need access to those services, interpretation and translation. And also we have a lot to learn about the pace of engagement and the clarity of information. If we, and I've shadowed and seen this in real time recently, like if you have to wait and have someone repeat your words and to make sure that they understand, it changes the whole dynamic. And so we have a lot to learn to apply that again universally.
I just want to say I did see that message from Megan Gonzalez about Haitian Creole patients and their need for education. It's a great opportunity to, I would like to encourage you and invite you to connect with some of those patients and really learn more about their experiences and what is relevant to them. And we have these sample tools available, but you can even ask them, like, when you see this tool, is this helpful? What would you change? What would you adapt? And so in that way, we can make sure that they are receiving the information that they need. And you might discover there are additional needs that have not yet been considered that may be specific for that cultural group. So I would love to see what you're able to do in that area.
And I see the follow-up about policy. And so I'll put a link to the AIM documents. And so that's little p policy with regards to what the national standards are. And then the Maternal Health Learning and Innovation Center, and I'll put the link to that in the chat. Then that has a group leading big P policy with regards to maternal health and the Momnibus and others. And Sarah Verbies, I don't know if you want to speak to that a little bit while I put in the chat.
I think all these policy suggestions are great, and I do think that we need to be working on all fronts, for sure.
And from my perspective, again, that's what I mean by justice, is that we need to be addressing unmet diaper need and food insecurity if we had quality education and affordable housing, and we're able to fulfill our potential. And so again, that's the reform and reimagining. And in the meantime, we need to connect people to programs that are out there, including WIC.
I had another question, just kind of things that were popping into my head. You guys mentioned doing social media to kind of put out, it's kind of one of the options of putting out information that is, the correct information. We see TikTok and all these sites that are giving information that probably isn't like the most helpful, but again, it's TikTok and there is a large following for a lot of influencers on there. So I guess my question is do you have possibly any thoughts about starting a TikTok? Because again, it has become one of those avenues, with where people are finding information.
We have not. I wish we had Suzanne on the call. She's our communications guru. Right now our strategy is to create videos that others are more than welcome to share. We're inviting healthcare professionals as well as parents themselves to share on social media. One thing I can say in the focus groups, we are seeing a lot of people going to social media and And it's interesting because it brings to question how much information and when and how accessible. And it's almost like this on-demand kind of approach works, but also the timing. So when we first did our first set of videos, I wish Suzanne was on, we had like a video that was about 1.5 minutes or 2 minutes long. And it was, and it had a good launch. And then we had a shorter version of it to 90 seconds, and it shot off exponentially. And so for those who do have a lot of good content out there that is accurate and want to get it out there, the more the merrier. We have learned the shorter, the better, and the clearer. And it does help having people that they can relate with. We found that some enjoy having a healthcare provider as an example of showing that they actually care, that they want to know they're on your side. And there are some that like, a fellow mom having a conversation. So there is a lot of opportunity in that space.
And we are on Instagram, Facebook, and Twitter. But yeah, all the things are needed. I think a key thing that I'm proud of is that our tools are open access. I wish and I implore others to grow that. It's sort of challenging to strive for health equity and having inaccessible resources.
Do we have any other questions for our speakers? I see Dr. Tully added her email, so if anyone has additional questions, you can also contact her.
I'm sorry, I have a quick question. I'm riding more with New Haven Healthy Start in New Haven, Connecticut. And I'm just trying to think, I mean, this was a really, really great. But is there anything that you guys are doing to push this information around postpartum to the fathers of these mothers to see what dads can do to support mom around that? Because all the information I get around this, I try to share with my dads just so that they can be supportive to mom around that, because that's really, really important that's probably one of the major resources that a mom would need, the support of dad. So if there's any way things that we can do positively that dad can do to be that support to mom around this particular issue when that does happen.
Yes, thank you for that. And I put a link to a partner organization, Reaching Our Brothers Everywhere, ROBE. And we need this as part of routine care for dads and all companions and grandmas. And so I think a lot of the 4 trimester project materials are intended to be for family and, peer discussion. And there's so much more that needs to be done to, and this is what I was trying to speak to, that we need to talk to whoever's there and not have a back turn, but we need to say your name, and we need to, it's almost comical, some of the warning signs are if you see or hear things that other people don't, and like you would never know that. With regards to maternal health warning signs, you need other people. And so we need to equip them. And so we have things in progress, but please, everyone in the chat, share other connections, because that's critical, because it's way too much. It's totally inappropriate to put everything on one person, whoever they are.
And I would also say that even some of our tools are plans, like for example, our postpartum planning tool is meant to be a conversation. And full disclosure, I actually used the postpartum tool for my second born and with my husband, and we talked about what do we need as a family during this time period, including visitors. You know, do we want to have visitors over and what times are appropriate, or what will actually help us and what is not helpful, and how to have those kind of conversations. So some of our tools are meant to foster those kind of conversations and really talk about what would help the whole family thrive during the postpartum period. So I love the idea of really, inviting fathers and other partners to be involved in the process of discussion of going through this experience together.
Rodney, I saw you smile when you said reaching our brothers everywhere. Are you connected with them too?
Yeah, I was gonna say from a man from Atlanta, so that's definitely that's my man. I'm good brother, man. I know you also got reaching our sisters everywhere too. So
Yeah.
That's a good brother, man. I'm telling you, I'm so proud of him. But I'm definitely gonna reach out to him because we definitely chatted at the last Healthy Start conference. So I'm definitely gonna reach out to him again. So thank you.
So you're welcome.
I see. I'm going through the chat trying to give thumbs up and hearts to everyone. I'm not going to get to them all, I fear, but I see your comment, Tina, around speaking with respect and kindness. And I think I'd love for you to come on, or for others to share. There are lots of words that work. And we should practice that in simulation, and Kimberly can speak to interprofessional education. And so we can and need to be trained to do this, and we need to be accountable for it. One of the things I think I did not mention in the postpartum discharge change package is that the recommendations include having patient-reported outcomes as part of clinical dashboards. We need to know when we're doing well and by the people who are being taken care of, in addition to the process measures and the health outcomes. And so I'm really excited for that to grow. Tina, I see you.
I think that I had the honor of working as a doula for like 10 years. So I attended a little over 250 births. And so in that time frame, seeing the way that oftentimes partners were sometimes seen as an afterthought, right? So depending on who the partner was, I saw it more in young families, in same-sex couples, and in Black and Brown families, where sometimes the healthcare providers would look to me, as this older white woman in the room, as like, I'll tell you the things. And it's like, but I'm not going to be there at the house tonight, tomorrow, etc. Right? Like, you need to direct this towards the family that I'm serving. And so sometimes it was my role to kind of direct it that direction, that way. But I know that at a NICHQ meeting, somebody shared a story about their partner even speaking up for them in the birth room, and the police being called and them being removed when they were not being, and it was a Black mother, right, and Black father, and they weren't being violent in any way, right? But when a strong Black man is speaks up for his partner, sometimes, right, the healthcare providers don't act the right way. And now you've caused issues. You've taken him out of that space. He didn't get to see his baby be born. You've started them on the wrong foot. And we just saw that story out of Dallas with their baby being taken from them. You know what I mean? We're doing such a disservice to so many families, and we need to raise everybody up and pull everybody together, not separate and cause harm.
And that's what I mean about supporting that mom. mom could have used all the support by having dad there. That's
Yeah.
better for her than having them removed. Now she's stressing because they're removing the father of her child who's there to support her to help a healthy delivery. So as opposed to trying to help her or whatever they constantly think they're doing, they're only hurting her in all the aspects, and even hurting the baby.
Yeah. And there's so many things that happen during that birth experience and in the immediate postpartum that if your partner or a family member or someone who's going to be with you isn't present, they're not getting all of that information. So you're being sent home without all of that valuable information, right? So, and also the language barriers, I've seen that happen too, right? Where there was no translator brought in and they're saying things and I'm like, you got to slow down and you need to find somebody who can share this information. Right. And it should never be the role of the doula to have to do that. The healthcare providers themselves should know to do that. But it's that culturally competent care that maybe isn't being imparted in med schools, right? So we need to work on that.
And the gentle way to say it, right, is that the system is far from optimized. We were discussing this morning, and I have a few of the practicum students on this call, and feel free to come on and speak to this directly, but we've filmed in the hospital as part of the patient safety learning lab, and we've been coding the videos of families' postpartum stays to see the things as they unfold, including, you know, when healthcare team members are present and what they say and how. And this morning we were discussing just this birth certificate and like the documentation that's needed for someone to be named as the father. And we could tell folks that in advance, and not doing so, then we have an example of a whole stay coming undone and then devolving into a conversation about DNA tests and things like that. And that is incredibly inappropriate and stressful. And we can change that.
I'm going to add one more piece that I think that paid family leave is such an important factor in this also, right? Because what I did see, I'm also a lactation consultant. So what I did see different during COVID was partners being present at my visits that had never been present before, right? And so the ability to stay home, because I myself, with my second baby, my husband went to work the morning after I had that baby, right? And so I was just alone in the hospital, and then, you know, he picked me up after work to go home. But right, like parents being able to have that at least a week or two. I mean, gosh, it should be so much more than that, right? But partners not having that opportunity. And then that was the biggest positive I saw during COVID, was partners actually being present more. I mean, hopefully that meant they were working from home and not, you know, not unemployed at that point, right? So, but just presence.
So it is 12:24. I just wanted to see if there were any last questions. I know our speakers, if they're still available, will be staying on for a bit if anyone had any additional questions for them. But I'm going to go ahead and stop the recording, and you're welcome to stay on and ask your questions. But feel free to also log off. And I do appreciate everyone staying on and having just such a great discussion on this webinar. You'll probably receive an email from me in the next day or two with the recording to this webinar, as well as the copy of the slides and a survey from CityMatch, kind of trying to see what more information or what topics you guys are interested in to, you know, continue these great discussions as well, because that's what we're here for. So thank you everyone again.